Good afternoon or good morning, depending on where you're logging in from. We are so excited to welcome you to our webinar today, sponsored by LymphaPress, which has the only device indicated for the treatment of lipedema, the Optimal Plus. And our topic today for Lipedema Awareness Month is all about lipedema. I love this colorful slide that begins the presentation because it really talks about the tribe. And aside from having a product that serves this patient population, what I didn't count on were those lipedema patients grabbing my heart. They are resilient, they are tough, they are their own advocates. Many have gone years without being diagnosed. This painful fat syndrome could have shut them down from living, and yet so many of them are inspirations to me and to so many people. We hope today's information inspires you further because information is power. The agenda for today's meeting is including what is lipedema, and Dr. Seo is going to be transforming my slides for me and moving them forward for me. We're going to talk about what is lipedema, the psychosocial impacts, because it's a painful fat disease, but there is pain psychologically to having this condition. The co-occurrence of obesity and lipedema, the ketogenic lifestyle for lipedema, and then we're going to have questions and answers. And here's what's really exciting. Because, ladies and gentlemen, there are prizes to be had as we move forward in the slides. Your questions and answers are solicited. In fact, throughout the presentation today, feel free to type in your questions and we will have you vote on what questions you most want to see answered. The top 12 questions we received today, you will get your very own copy of the Ketogenic Solution for Lymphatic Disorders. And with that, I want to introduce one of the co-authors, Dr. Catherine Seo. I'm a big fan of Dr. Seo. She is the producer and director of the documentary, The Disease They Call Fat, a founder and director of Lipedema Simplified, and the executive director of the Lipedema Project, which, by the way, if you are a patient watching this, those are great resources for you to dig into and find your tribe. She's the co-author of Lipedema, The Disease They Call Fat, an overview for clinicians. She's an excellent communicator and she has a degree in media psychology with a special focus on body image. She has her PhD, by the way. She's not just educated in it. And I will let you, Dr. Seo, say the rest about yourself.
So first of all, thank you so much. I want to just say that though we've been invited by many vendors, this is the first time we're actually doing a webinar for a vendor. And I personally have a LymphaPress. I use it and I just love it. And more than even the LymphaPress, I love all the people involved with it. So I'm appreciative that I have that resource and that you guys have been so fabulous. So I want to say that the reason that I'm here, the reason that I've done everything that I've done over the past number of years is because I was looking for answers for my own lipedema, lymphedema, and I've struggled with obesity for over 25 years, 65 years, I wish. You know, it's funny, that's a slip because it's been a lifelong struggle. And I'd like to briefly introduce my colleagues. So Dr. Carmody is an internist. He's an assistant professor at Harvard Medical School. He's certified in obesity medicine. He's one of the co-authors of the book that we wrote on lipedema. But what I really want to introduce you to is that he was my incredible rock of Gibraltar. He's retired now. He was my primary care for 25 years. And when I walked in with issues that neither one of us could identify, unlike some of the stories that I'm about to tell you, he entered into partnership with me, asked me all the right questions, helped me to find ways to help myself. And he was incredible in so many ways. But one of the things is that he then began to not only work with me, but over 100 other women coming from all over the country came to see him. And he was able to help many lipedema ladies. So I'm so pleased to be able to share this presentation with us. And Leslyn Keith is the board president and director of research for the Lipedema Project. She's an instructor for closed training and consulting. She is the author of the book we're giving away today. And she has her clinical doctorate in occupational therapy. Her emphasis was on lymphedema and obesity. And she's been in practice for over 25 years as well. So, but I met her at the NIH, the National Institutes for Health, when they did their very first symposium on the lymphatic system. It was September 2015, and she was presenting her research. And she and I ended up in a conversation at the end of which we looked at each other and said, do you think this could work for lipedema? And it took about a year, because I was in Europe and she was finishing her research, when we began to explore exactly that. And she's going to share more about that in her presentation. And I'm happy to say that, that the three of us, along with colleagues, are in the midst of finishing a paper that will hopefully be published in a journal soon. So I just want to start off with this quote from the very first book on diet that was ever published in 1869 by William Banting. It was called Letter on Corpulence. And the very first sentence of his book says, "Of all the parasites that affect humanity, I do not know of, nor can I imagine any more distressing than that of obesity." And for those of us who dealt with this disorder, even obesity, and then lipedema, and then lymphedema, we can tell hair-raising stories about the impact on our lives. But let me start with, since we always have somebody new to our webinars, what is the fat disorder lipedema? It's disproportionate fat distribution. It typically, and this is a somewhat classic shape, but I have to say, what I found in these years of working with this, there really is no classic shape because there are many different shapes. But it's a smaller upper body with the fat distribution around the hips, the buttocks, the legs, where it spares the feet. If you can see in this image, her feet are not swollen. Her arms, though, her upper arms are. So those are the areas that tend to have the accumulation of this, what is often painful fat. So just a little bit, it's little known, it's generally misdiagnosed. It was identified in 1940 at the Mayo Clinic by Drs. Allen and Hines. It was the first article or anything that was published was their staff recordings. And nothing had been done until a small group of us started to explore and research. It's primarily in women. It initiates with hormonal disturbance, so it tends to initiate or exacerbate at puberty, pregnancy, perimenopause, or with any kind of gynecological surgery, it can do it as well, or any surgery actually. It's localized painful fat. I said already, thighs, hips, buttocks, some cases the upper arms. The thing about lipedema that is stunningly devastating is that there is no, to quote unquote, when I started, there is no treatment and it gets worse. So basically, most women are given that nothing is going to change it. You can't do anything about it. So I'll talk a little more about that. Generally, it's misdiagnosed as obesity, and women are told, you know, lose weight, come back when you've lost 50, 80, 100, 200 pounds. And 11% of women have lipedema and don't know it. And it looks different in different women. This is 4 stages as it progresses, but here's a number of women. They all have lipedema, but it looks different. And it depends on the stage, the type, and other possible comorbidities. And Dr. Carmody is going to talk about some of that. So here's the, if you will, the context for lipedema ladies. We struggle with weight. No matter what we do or how hard we try, nothing seems to work. We live with physical pain or discomfort as a result of the lipedema. But most women with lipedema are told that it's imagined because, you know, how could fat create pain? That kind of pain, physical pain. We live with fear that our condition is going to worsen and we might lose our mobility and end up in a wheelchair and bedridden. And in fact, I know women where that's happened. Often we harbor self-judgment and self-blame, live on an emotional roller coaster between hope of trying something new and actually trying many things, and then feeling despair and hopelessness when it doesn't work. Feeling separate from, different, not as good as others because of visible disfigurement. And we actually got a question on body dysmorphic disorder, which we'll address at the end of the presentation. The bottom line is we feel powerless because so many of us have dealt with it day in and day out and have tried and tried and tried and nothing's worked. So as Brenda introduced us, 11% of women have lipedema and most don't know it. That's 17 million women in the US and as many as 350 million women worldwide. And these are the stories. These are quotes from different women that we've worked with over the years. My doctor doesn't believe me and says I'm making excuses. It's just fat, lose weight, exercise more. My doctor says that it's my fault. My doctor says it's a crazy made up internet disease. My doctor doesn't believe me. And that's the plight. You can see why I feel so blessed to have had someone listen to me. And in fact, I wouldn't be here today if I didn't have Dr. Carmody listening to me over these years and asking me good questions and giving me answers that I could then explore and take to the next step. So I really do credit that connection and relationship with all of that we've come up with. So I'm going to talk a little bit about a psychosocial context. And as Brenda said, we say, find your tribe, love them hard. That's what we do. We work collaboratively. So the key was in taking a holistic approach. And we began something called the Masterclass series. We started in, Leslyn, I think it was 2017. Yeah, we connected in 2016 and we started some classes and we did a feasibility study to see if any of this would work. We had no idea. And so what we started to do is we started to put together a model that looked at physical, mental, psychological, emotional, spiritual, and social impact. Not only impact, but what kind of treatment, what kind of self-management, because we didn't have the ongoing support in the healthcare community. It's as simple as that. And so we did indeed put together a model, and we've been spending the last period of time really expanding upon that model. What I showed you just a moment ago is where it had been until very recently. So we started to define it. Like physical is the actionable self-management protocols. We've had women working on a self-management protocol from the beginning, and it's evolved. And so we have them defining next steps in nutrition, movement, and symptom management. mental and psychological, is developing a clear mindset where they can identify. There's so many places where they're often come in wounded, and so sometimes they're most of the time in such overwhelm. Someone can start anywhere. It's just, where are they in this present moment and where do they start? So part of the model is saying it's not a prescription where you follow a set road. You actually choose it yourself with guidance and work, and what is the very next step. So it's a mental and psychological process. Emotional, how to learn to identify the places where there is that feeling, emotions, and patterns of behavior that are very limiting, especially when you walk around the world in a disfigured body. We know that's a lot of my research, is looking at what stems out of the media and what happens for women internally and externally. And then there's a spiritual component. And by spiritual, we're talking about an awakening to one's own essence, because every single one of us has a gift that's so precious, and it's getting past what prevents us from allowing that. And so we work with developing inner awareness as well as outer calm and the ability to walk through one's life with a chronic disease that's disfiguring. And then finally, and not finally, but basically, it's the social, because it's through the connections that we make with one another. We're a group, a team, a tribe of women that we've had to ourselves look for answers and then share with one another. So our social connection is one where we cultivate support and colleagues and community, and we allow ourselves to be known by one another. And in that environment, women heal, because underneath it all, it's a sense of belonging. So some of these, we recently did a survey, and that's another webinar, but these are some of the words that were shared as to the results that women had. Pain elimination, increased mobility, weight reduction, personal diet and movement in the physical category. In the mental, education, mindset, planning, and protocol. In the emotional, self-acceptance that led to recognition, compassion, affirmation, and self-care. And spiritual, transformation, benefactors. We actually do something in our groups where we call the benefactor meditation, where you envision and begin to recognize the ways in which you are loved and cared for. It helps to allow us to care for ourselves. And of course, an increase in the quality of life, life force, essence, and ultimately presence. And the basis of what we're doing really is social connection, which leads to friendship, which leads to community, where women have each other's backs and they're supporting one another. And it becomes a home base and a foundation. And, you know, I have to say, and I know Leslyn will echo this, and I'm sure Dr. Carmody will, when we started, we didn't know what the hell we were doing. And when I say that, it's like we just said, okay, we knew that we had some models. We knew that we had skills. We knew that we had tests. We had different things that we could do to help. But how it would ultimately come together was a community emergence. It really came out of the work that the women did. And I'm going to end with their words, not mine. And I'm going to share with you two women who went through our 6-month process. This is Marlene.
I've been living with the pain for about 14 years, and and I'm just wearing down. But I got to the point where the last few months or even longer, I do not want to live anymore. And I keep, when I get into bed at night, I keep praying to God, would you please release me from this body?
That was as we were starting, and I'm sorry, I don't know why that bar is there, but I'm going to play. This is at the end of our 6 months together.
My psychologist couldn't believe it yesterday. It's like, my depression is totally gone. And I've been depressed for really 8 years, 18 years, but severely 8 years. And it's just gone. So, and my pain is very minimal. So it's been remarkable what this has done. I'm back among the living.
I have to be honest. It was right after this one where she was talking that Leslyn and I and the team got on our debrief after that session. She shared that in a group session. And of course, she's given us permission to share all of this. And we look, the team went, oh my God, this is working. And this is Marlene's before, and this is the after picture she sent us. And so, and this is Jerry.
Probably about November, I said, I've had it. I'm tired of doing everything that I'm supposed to be doing. And I don't have time in my day to do everything and then have a life and still becoming more debilitated. I have gone from being just down and out, almost hopeless with this disease, to knowing that there's hope, knowing that the light at the end of the tunnel is not a train anymore, but it's light. I can see the end of the tunnel where I can keep going.
And one thing about any healing process is we like to think it's a straight line that goes from the bottom left to the top right. It's not the case. Jerry had some slips, and she sent me this last fall. And she said, you know, she regained some weight, she was back on track, and she was even better than ever. And that, you know, so much of the work is empowering women to take care of themselves, that it is so much a part of this particular disorder. And so with that, I'm going to turn this over to Dr. Carmody.
So hello there. I'm going to actually just bring you through some more, try to be as scientific as I can, and also try to give you an idea about something that I think I want to, if you do have lipedema, then that is certainly what Catherine has introduced you to and shown you pictures of. And then what I want to do is I actually want to respect my clinical observations, which is that I did see in a significant percentage of people, probably greater than 50% and going toward 80% of people that I saw also had obesity. So I thought that I would talk about the two together. And so this is basically the two together, but in different people. And I do apologize for the depersonalization of these two persons. You know, and we do this because of HIPAA, et cetera. But I want you to just spend a few moments on the way that their bodies are shaped. In the woman on the left and the woman on the right, and that's how I'm going to refer. And I want to just, for me, the most striking feature is sort of at the hip line. You can see that the woman on the left has tissue that is bulging, you know, at the hip line, where the woman on the right, at least covering her hands, and hopefully she doesn't have this bulge, but I don't think that she does, has actually no bulge at that. It's a very straight line that starts above her waist and curves around the hip and then down the upper part of the leg. This is a distinct pattern when you begin to see it. And what I want to do is take you below that point where you see the thighs of the woman on the left who has lipedema as being, if you look at the outside of the thigh and the inside of the thigh, that it is a straight line almost. It's almost like what is referred to as a stovepipe. If you look at the woman on the right, she actually has a shape that is coming in from the outside straight down on the inside. So what we see is this stovepiping of the upper legs, and we actually see that repeated in the lower legs all the way down to the ankle, but not involving the ankle with the patient on the left. And so what we have here is some of the features of lipedema. But the other striking thing is to look at the waist. The woman on the left has her thumb and index finger on her waist. And you can see that there is a shape to this waist. There is the body from the lower part of the breast to that waistline, that it actually has a nice straight line and maybe almost curved inward. As depicted on the left part of her body. But the person on the right actually, it's hard to identify the waistline. It is bulging at the waistline. And so that's the difference between these two, where on the left, this is lipedema, where it's a problem of the upper arms and tends to be proximal arm, the hips and buttocks, and the upper legs and lower legs, and any combination of those. That there's different types of this, but different combinations of those. But they tend to spare their waist and to their shoulders. That the adiposity of that part of their body is so much less. And in fact, they complain that when they lose weight, they tend to lose weight from the shoulder to the waist, creating or emphasizing the disproportion between that lower body and their upper arms and the middle part of their body, so that it becomes disturbing to lose weight. But I'm going to tell you that in my clinical experience, there is more often a combination of the body type of the person on the left and the person on the right. I think from Dr. Xiao's lecture, that lipedema is the person on the left. So to go on, I'm going to ask you to look at this statement. This is by Lee Kaplan. He's a physician that is of great prominence in the Boston area in terms of his work with obesity. And I want to have you look at the second part of that line, which is obesity causes overeating. I hope that you know lipedema is actually a disease. And I want to tell you that, and you probably know this also about obesity, but obesity also is a disease. So we are talking about processes that the person has and has not, and is acting on or acting with. So the top line, overeating does not cause obesity, really speaks to the fact that it is obesity itself that is driving overeating. So that rather than hold yourself as the cause or the problem of overeating, you should really feel that I have this disease and I need to actually deal with it as a disease. And so what I want to do on the next slide, which is overwhelming and complicated, is tell you something about the body and the way it regulates weight. This is just to let you, this is not any abnormality that I'm showing you. This is how everybody works. So what I want to drive toward is that this whole system is actually setting your weight at a certain point. And it's very difficult to get off to get either above or below that point. You can do it, but you have to do it with knowledge and effort. But also with respect to the fact that this system wants to keep you at one weight. I'm going to look at the organ in the middle, which is the brain, and which it has sort of there's a real metabolic part of the brain, which we'll get into in the next slide. And there's also this emotional cognitive part of the brain also that is and they're working together perfectly. We see that the environment and lifestyle have a very heavy impact on cognitive and on the cognitive emotional brain and on the metabolic brain. And we look at some of the things that make up that environment and lifestyle. And I'm going to go to the right part of this upper pink area, cues and social habits, the clock. That is how you regulate the day, your day from beginning to end. The availability of food, the reward of that food might represent to you, the palatability of food, all of those are actually create wide individual variation. On the right, you see a green bar, which has, so your weight has a genetic basis. It has an epigenetic basis, that is a habit or an expression that you've inherited from your lineage. It is imprinted, and it depends on early life events. So here we are, we're thinking, oh, this is just I'm overweight. But in fact, you're overweight for the most complicated set of reasons that are all not, that can be worked with, but are difficult to work in. And if that weren't enough, we just dealt with the brain and some of the genetics of this. We have the gut, which is the pink organ, the muscle, which is the red organ, the fat, which is the yellow organ in the middle, the pancreas, the organ below the fat, and the liver above the fat. All of those organs are actually communicating to each other and setting the tone for your body. In the next slide, which is also very complicated, I want to just give you a little bit of idea. In boxes, I've actually represented what was pictures before as just labels. Blue for the brain, pancreas is sort of not quite yellow, orangish yellow. Adipose tissue is yellow, muscle is red, and gut is green. It is a fact that the most complicated endocrine organ in your body is the gut. It is producing the most hormone. It has it has neural connections as well as hormone connections. If I bring your attention to the gut and look at this little thing below it, it's called ghrelin, very small little letters there. That is a hormone that's contained in your stomach wall that before you eat starts to rise to a very massive level and stimulates your brain, goes right to your brain and stimulates your appetite and causes you to persist in appetite through your eating. Leptin, the one below it, is really most produced by the fat, some by the gut. But leptin is that elaboration that goes to the brain and tells the brain, shut off. Your appetite is down. You can stop eating. So that you're seeing that there is a competition or of hormones, of neurological signals, of different areas of the body that are very well put together. And on the next slide, the misfortune is, or maybe the fortune is that we now know that this disease, obesity, has different types. We know that there's 36 types of obesity. We feel that in the next 3 or 4 years, there will be 90 obesity disorders. And some might actually put lipedema as one of those disorders. So leptin deficiency, remember leptin was telling the brain, please shut off. And if you have a deficiency of that, then in fact you will have increased hunger. There's an interesting one that I put in the middle here, which is called the circadian disrupted environment. That is, If you are not living a day with regular cycles, if your sleep is disturbed, then what will happen is you will tend to gain weight. In most people, that is what happens. And on the next slide, I'm giving you an example of the fact that the weight regulation is different from person to person. Here we have an example of Atkins diet. There is, on the bottom line, there's refers to weight change. And the red line to the right of the red line is weight gain, weight loss, and to the left of the red line is weight gain. So you can see here's a diet, Atkins diet, and one could say, oh, this is what everyone should try to do, is the Atkins diet. And in fact, if you take everybody and have them do the Atkins diet, you find that a very small percent of the Atkins diet really works. In other words, people who lose 10 to 15% of their weight, up to 25 to 30% of their weight on the Atkins diet represents not more than 15%. Where people that are losing a small amount of weight in the 8-pound to 15-pound range, it represents 40% of people using the Atkins diet. And then there is, in fact, to the left of the red line, almost 25% or almost 15%, 20% actually, that are actually gaining weight on the Atkins diet. Can you believe that? That's gaining weight. So here you set about using the Atkins diet and you gained weight. I think there's something very exciting that Leslyn Keith is going to tell us about, that a keto diet has perhaps some advantage in the lipedema arena. On the next slide, I want to show you that here is obesity. Again, we're seeing the same pattern. The pattern is that people lose weight with regular exercise, well measured and done for weeks, and other people gain weight in doing this. And this pattern, again, on the right side of both of these curves or histograms, you're seeing people gain weight doing exercise. And you're seeing some people, but not all people, lose weight. And you're seeing them lose variable amount, doing exactly the same exercise and eating exactly as they did as they came into the study and were studied 3 months before the study started. So they were eating the same, but they imposed this exercise, and actually some people gained weight, other people lost weight. So this pattern of nothing works for everyone is the problem that we're up against. In other words, that complicated regulation system makes everybody different. You should consider yourself as one person. And so the strategy that you have to adopt with this is contained on the next page, where you have to do experiments. You are a one-person experiment. So your disease, be it lipedema, be it obesity, be it obesity with lipedema, you need to actually experiment. So you can make a lifestyle change, which is in the diet. You can do you can also do fasting. You can do better sleep management and get increased numbers. A simple thing that I told most of my patients is, if you're getting 5 hours of sleep, that is causing most people to gain weight. If you're getting 7.5, that's a significant change and will cause you to lose weight. So sleep management is an intervention that I would say, here, try a sleep management intervention. It'll be 6 weeks. Try to change nothing else about what you're doing and actually try to get more sleep. That is what, but you can see the lifestyle change can include stress reduction, remember the environment and the lifestyle. It's very important. So far, we haven't talked anything about food. We talked about changing how you slept, and we've talked about reducing stress. And those are environmental, lifestyle interventions that have nothing to do with food yet, but actually have to do with other things in your life. Medications are available, surgery is available. Again, appropriate in some people and not appropriate in others. But this is something that you'll need counseling on, and a professional relationship to sort of to start to do more complicated changes. But you can start today. You can say, I'm going to get more sleep, and I'm going to measure my weight now and 6 weeks from now, and I'm going to see if that had any impact. I also want to tell you that if your body mass index is greater than 40, there is a 70% chance that you also have this condition called obstructive sleep apnea, which is going to cause you to get very ineffective sleep. So the next slide, and I'm not going to spend a lot of time here because Catherine has done a tremendous job here with the stories that lipedema patients tell. And on the next slide, and she's also covered this in her slide. So she's told you, what you're looking for that, as well as the next slide in which she's reviewed stages. So what I want to do next is I want to just call out something that I hope is all true, and that you know it now, that number one, lipedema and obesity can be together. However, they are distinct. And when I'm looking for the distinction, I'm looking at disproportion. I'm looking at time when you increase in your weight. But in lipedema, I'm also looking at tenderness to pressure and easy bruisability as definitely the symptoms that occur in many people with that. And they're distinct from obesity and then distinct from lymphedema. I want to just go through quickly some treatment options. And I'm going to present a slide to you that sort of we try to understand what the treatment options mean. So this is going to be a little dive into the next slide, where I'm going to make an argument here that lymphatic drainage is a very important intervention, at least in the short term and for symptom relief. And what I've depicted here in the middle of this slide is the red capillary, the blood coming into the tissue, and the venule is the blood is going away from the tissue. What's happening when the blood goes through those capillaries, it's giving the rest of the body oxygen, but it's also giving it a tremendous nutrient bath as well. It's giving a protein bath to all the tissues. And what is also true is it dumps a lot of material into the space around this central figure, so that you can imagine this space is filling up, and it's the job of this structure to the right, which is this blue tube coming down, which represents the lymphatics. The lymphatics' job is to pick up all that fluid and actually deliver it back to the central circulation, which it's very capable of doing. However, in lipedema and also in obesity, but more in lipedema, the lymphatics are abnormal. In particular, there's an expansion of the lymphatic vessel size, but there's not an increase in transport. So if you press this area, you encourage fluid to go into the veins, but also more, you encourage it to go into the lymphatics. The lymphatics are just another way back to the circulation. So that manual lymphatic drainage is attempting to help you increase the lymphatic flow and push fluid into the lymph system. So that's its idea. So it is relieving in lipedemic tissue because it decongests. It takes that feeling of, oh, my legs are so heavy and I just feel congested and pained because of that. Certainly that's what this will do. So this is a great therapy, and Leslyn Keith knows so much about this. So then on the next slide, the second thing is liposuction that is used to reduce lipedemic tissue. So these are the observations on the left of what it does. And when you read down that list, you say, oh my God, this is it. This is what I want. I would say also look at the percent, look at the amount of change that there is, and unfortunately, not as much as you want. It is not 100% with each person that you have pain reduction. It is not 100% with each person that you reduce bruising. It's not 100% that you get a big change in circumference. It will occur, but there's a warning which is contained on the next slide. All of what you've just read on the previous slide is a problem in the sense that these studies were not controlled. In other words, there was not some people that received the liposuction and then another group who didn't, and to compare the two and how they did. So unfortunately, this is somewhat unscientific. It's impressive, but it's unscientific, because for it to be scientific, it has to have people with the disease, some of which receive the intervention and some of which do not. So they're really not actually allowing us to compare how much change really occurred. And they're not giving us a good scientific base to undergo liposuction. So you will hear that it's effective from people that have had it, but I also will tell you that there's been a lot of detailed meta-analysis on this, and it's not very scientific. So be warned about that. And I have had people gone through with good results, others with not so good results. So there it is. If you have some obesity with your lipedema, you know that that's a experiment that you have to engage in. If you have lipedema, I would encourage lymphatic drainage, thoughts about liposuction, but I think not. And certainly Catherine's report on her master class seems like a superb intervention that is not a danger, but is only going to help. And so on to Leslyn Keith.
Hi, everybody. I'm a little concerned about my sound. How am I coming through here? Is this coming out
great?
Right? Okay,
Great.
good. Good. So I'm going to talk to you a little bit about a ketogenic lifestyle for lipedema. Go ahead and go to the next slide. And but first, I would like to have an important caveat, because before you ever drastically change your diet, you should consult with your medical provider. So I'm going to give you a lot of information in this. But if you would like to attempt this yourself, it is always important to consult with your medical provider. Okay, next. So what is a ketogenic lifestyle? And as you can see from this picture, it is just real food. So this is real whole foods. It is not packaged, manufactured, processed. It's just different real foods that you would find in a produce or meat or dairy section in your grocery store. So the main concepts of this way of eating is to control for carbohydrates. So we're severely going to restrict our carbohydrate restriction. And you can see with the foods that are up here, I don't feel like I'm limited in my food choices, but I'm not eating anything that's very high carb. And then I'm going to prioritize my proteins. So I want to make sure I'm getting I'm consuming proteins that I like, that I enjoy. I'm going to pick those foods that give me those good proteins. And lastly, I'm going to fill into fat. And this is just with I'm just going to go to satiation. I'm just eating fats to bring me to that feeling full. I am not going to purposely try to really eat a whole bunch of fat. I'm just going to eat the fats that come along with those foods that I enjoy and go to satiation. So I want to talk about what is typically done for obesity, and now they're trying to use it for lipedema as well, and why it doesn't really work. And this is CICO, which is calories in, calories out. This is what we've been told the last 50 years, that it's this scale that's balanced between how many calories we take in through our food and how much we're expending through some kind of exertion or exercise or activity. And we want to eat less than we are expending so that hopefully then we would lose weight. So this is going to be a calorie restricted diet. It's going to be usually plant-based. Typically, they're going to recommend it's going to be low fat. It may be a liquid diet. It could be a packaged meal. So they're really restricting your calories, not depending on what you're eating, except maybe it's plant-based, and then have you exercise a whole bunch. And so what happens with obesity, but then also what happens with our women with lipedema? So it tends to result in, first, constant hunger. So you're feeling deprived, you're not getting enough to eat, it's essentially a starvation diet. So you feel that constant hunger. So that's that feeling of deprivation. Keep going, Catherine. And then we end up with that fatigue and irritability, that really lethargy. You're not getting enough energy, and it's on that starvation diet. But also, unfortunately, what happens with our women with lipedema is they have increased pain. They're already coming into this with pain, but this way of eating increases their pain. And then, yes, they do lose weight because they're starving, but it's only on the upper body. So it seems to accentuate that body dysmorphia, that difference between the upper and lower half of the body. But here is another theory about weight loss and what we can do for lipedema. And this one, this metabolic theory of weight loss, this tells us it depends on not how much we're eating, but what we're eating. And it's because of that insulin response to the different types of foods. So we have carbs, proteins, and fat. All food is made up of those three micronutrients. Insulin is the one of those is a hormone that it's one of its main jobs. One of its many complex jobs is to store fat. It stops fat burning and it stores fat. And so you can see when you eat a carbohydrate, you have a huge insulin response. And so now at that point, it's going to say, let's store fat, let's not burn fat. And then with protein, we have a moderate response. And then when we eat fat, we have pretty much a flat line. So we're not at that point going to be storing fat. We'd be more on the side of burning fat. And so this way of eating, it results in that nice, stable blood sugar. We're not going to have those mood swings and going into hypoglycemia. We're going to feel satiated. So even though we might be eating fewer calories than we typically do, we're full. So we don't need to eat more. And so our mood is stabilized, which is a huge benefit. We're looking at those psychosocial issues with lipedema. And then, but even though we feel like we're not eating as much or as often, we have this increased energy and vitality. A lot of women will talk about how they have, now they want to be active. We're not going to exercise to lose weight. We're going to, after we start losing weight and feeling better, we're going to start to become more active and exercise. A lot of them will talk about the clarity of thought. That brain fog will lift. And most importantly for women with lipedema is we have decreased pain. And what we're finding anecdotally in our groups is sometimes within 2 weeks, the pain decreases and sometimes completely resolves. You heard what Marlene said, that her pain was minimal. So that is pretty spectacular on this way of eating. And not only that, we're losing fat on the upper and lower part of the body, which never happened before. So this, I use a food pyramid because a lot of us are grown up with a food pyramid, but you can see this is a food pyramid turned on its head. This is very different from your typical food pyramid. This is the ketogenic way of eating food pyramid. So you can see at the base of the pyramid, it's all of our healthy fats and proteins. It's showing you a couple of choices there, some plant-based, some animal-sourced. And then we're going to supplement that with non-starchy vegetables. So you can eat vegetables in this way of eating. And at the very top, this is just our treats. So we have a minimal amount of those treats that may include high-fat nuts, seeds, and lower glycemic fruits like berries. So how do we modify this way of eating for lipedema? So it's even, you know, have this basic of ketogenic diet is carb restriction, get good enough protein and fill in with fat. But how do we make it a little bit more specific for lipedema? And one thing that people do is they typically will replace foods like flour, wheat flour, and they're going to use instead nut flours, which is going to be lower carb, but it's still going to have plenty of carbs. So we're finding is that if you still eat lots of baked goods, but you're still making it with coconut flour, almond flour, it doesn't work well with lipedema. But we're finding if you use some of these replacements or some of these foods that you traditionally ate before, then we can have our pain doesn't go down as well or comes back, and we have a weight loss stall with lipedema. So we suggest that you avoid those nut flours, you avoid any kind of artificial sweetener. In the beginning, we say just don't have any fruit at all, but then typically a lot of women are adding in just those low glycemic fruits like berries as they've started to get onto their plan. And absolutely, and this is for everybody, avoid those highly processed vegetable and seed oils. They're very inflammatory. So we say, you know, try to eat some nice fats. We're not talking about these seed oils that have been subjected to a lot of heat and chemicals, canola, soy, corn oil, stuff like that. We're avoiding those types. They seem to be highly inflammatory. Some other things to consider if you're using this way of eating for lipedema is try adding some animal source foods. A lot of people who have fought with obesity or what they thought was obesity for much of their lives believed that a plant-based diet was the best way to eat and that would help them lose weight and it was the most healthy. And especially women, we tend to be vegetarians. And what we're finding is that having those animal source foods are going to be more healthy. So have the ones that, the animal source foods that you feel comfortable with eating. And do you feel comfortable with having fish, eggs? I am a big proponent of steak, but have the thing that you are the most comfortable with and try to add more animal source foods into your way of eating. And then the next thing is that Dr. Carmody already talked about this a little bit, but intermittent fasting, it's basically eat whenever you're hungry, but stop when you're full, no snacks because you're not hungry. So we're traditionally used to eating all the time because we're always hungry with a typical low-fat, calorie-restricted diet. We don't need to do that with this. We get satiated, we're not hungry for another 12 to 24 hours. People using this, the ketogenic lifestyle, tend to only eat once or twice a day. So we're having these discrete meals, there's no snacking. And so in between those discrete meals, that's our intermittent fasting. We're not eating during that time. And this really brings you in tune to your body. Listen to what your body is telling you. You had a particular food that is considered to be a keto food, but it didn't agree with you. Listen to your body's signals and say, well, maybe I'm not going to have that one anymore. I'm going to do something else.
Leslyn, I just want to interrupt for 1 second.
Yes.
And our participants usually know that we have generally a hard stop 1 hour into a webinar. This is way too riveting and interesting, and we're going to keep going. For those of you that are on your lunch hour and need to jump off, please know that after the recording is done today, including all the Q&As, you're going to get a link to it so you won't miss anything. We want you to know, for those of you that need to jump off, we so appreciate you being here, but I'm not going to stop this. This is way too good. So I'm going to throw it right back to you, Leslyn.
Yeah, thank you, Brenda. And I am almost done, and then we have some questions that we will do those questions. But again, you guys will all get all of that recording later. So I just want to draw your attention to this fabulous study that was completed in January of 2019 and in Norway. And it was a small pilot study, 10 women with lipedema, and they wanted to see what happened when they used a ketogenic diet and what happened to their body composition, their quality of life, and their pain. And so the design of the study was that we had 7 weeks of a ketogenic diet, followed immediately by 6 weeks of normal Norwegian fare, a typical high carb, like a Western diet type of eating. So let's look at the results on the other page, the next slide. So one of the outcomes was weight loss, and as a group, after 7 weeks of a keto diet, they lost an average of 9.5 pounds. Their hip measure had a significant decrease. This is on the lower body. They lost lower body fat around the hip. And then after the keto diet, the triglycerides, the blood numbers went down, and it was significant. And the pain was also significant to decrease. So then they went on to 6 weeks of a typical Western diet. And after that time, their weight loss maintained. They didn't lose any more, but it was maintained. Their hip measure stayed the same, did not go down anymore. Their triglycerides, the blood numbers went right back up to where they started just after 6 weeks on this way of eating. And the pain, despite no further weight gain or loss, the weight stayed the same, the pain went right back up to where it was. So that tells me that the pain is not merely a mechanical situation. There's something else happening here that, that causes that pain in lipedema. Let's go to the next slide. So just to show you a couple of responses that the people have had. This woman, Shelf took her pictures and cataloged her journey. And you can see that in less than 2 years, 181 pounds lost. And her quote is, no surgery, no exercise, just food. And it was ketogenic food. And you can see that there is significant reduction in her lower body as well as her upper body. She's more proportional. It's not like she only lost upper body. And so what we're seeing anecdotally with our group is that we have increased energy, decreased brain fog, fat loss on the lower body as well as the upper body. The pain is resolving or at least decreasing significantly. And all of this is without hunger, which our typical way of dieting, of trying to lose weight with these diets, is that we are just hungry and deprived all the time, absence of that feeling. Just another, a couple of before afters. This is Mindy, and I have 2 pictures of her before she used a ketogenic lifestyle. And she is a colleague of ours, and she presented with me at the NLN in October. And you can see what happened to her in less than 3 years of a ketogenic way of eating, pretty spectacular. And you can see her presentation through the recordings from Boston. And next. This is a patient of mine. You can see that she had this really typical lipedema look with cuffs kind of at her wrists, and you can't see it with her pants, but she had those leg cuffs. And then after 2 years of using a ketogenic way of eating, she just looked spectacular, and a lot of different changes with her, more energy, decreased brain fog. Her pain is absolutely gone. So a complete change for her in just a couple of years. So I would like to suggest to you that this, as an overall program of managing lipedema, using a ketogenic lifestyle is going to help people manage their lipedema and live well, live healthier, live happier, improve quality of life by using this way of eating in combination with all the other supports that we're talking about. Thank you very much.
That was amazing. Those photos don't lie. I had goosebumps, and pretty much throughout the presentation today, we know that, thank you so much, Leslyn. We know that we have lots of questions, and I want to bring them forward for our panelists. The top 12 voted questions are going to get a copy of the wonderful book, The Ketogenic Solution for lymphatic disorders. So that's exciting. The number one question, will we have a copy of the PowerPoint presentation because this was amazing? The answer is yes. Everybody who is registered for this is going to get a link with the webinar in its entirety. We have people that are taking photos of their screens during it. It's just wonderful. A question that I believe you answered, Dr. Carmody, but this was one of the most popular questions, and maybe you could restate the Reader's Digest version. How do you determine the difference between obesity and lipedema?
So this is a tough one. You know, I think that there are not a lot of practitioners that can help you diagnose lipedema. So that's the drawback. I really think that to look at yourself in the mirror and to sort of take notice of whether you have some disproportionate distribution of your fat, of your adipose tissue to your leg, to your hips, your buttocks, and your legs, and you spare the center part of you from your waist to your shoulder, maybe have some enlargement of your upper arms, mostly the proximal arms. Those are all things that go toward lipedema. I think that practitioners are becoming a little bit more knowledgeable. I think an excellent way to go to your practitioner is to go to Catherine Sio's website, where there is available a book that you can give to your practitioner and say, this is a diagnosis that I think I have. And I think that that's probably the easy to look at yourself and to sort of be convinced, or at least questioning. The book is online for your practitioner. There is more information for you online to help you sort of make clinch the diagnosis or have a high degree of suspicion. And people are warming to this a little bit. You know, it's not so foreign, but it's not that somebody is an expert and can make that decision for you. But a lot of people have been very successful. People that came to me asking, do I have it? I can't say that there was more than 2 or 3 that didn't. They knew they had it, and I just confirmed it.
So many find hope when they Google and they see photos of someone that looks just like them. And
Yeah.
then all of a sudden, there is this sense of hope that maybe
Sure.
there's an answer. And you spoke to something at the very beginning of your answer that has come up in a lot of the questions, which is, how do I find somebody that will diagnose me? And I do know, Catherine, on your website, there's an interactive map.
Yes, in lipedemaproject.org, there is, if you go to the website in the upper right-hand corner, a link that says Find a Doctor. And if you click that, there's an interactive map that lists out doctors, surgeons, therapists, and something else. I can't remember the other one. Anyway, several different options by different color flags. And it gives the doctor's name, the specialty, and the phone number and website.
It is comprehensive, and it's a great tool to find somebody in your territory, in your region, that will diagnose lipedema. The frustration for so many women is, I talked to a woman last week, it was 40 years. I knew there was something wrong with me and I was not diagnosed. So getting a diagnosis is such a key. You mentioned surgery, and that has come up in a lot of the questions as well. Dawn Teeters says, it's so true that what works today may not work tomorrow. I did Atkins in my 20s and 30s. It worked great. I lost 20 pounds. I've been keto for 2 years. I've lost 30 pounds, but it's creeping back. What would you each like to say about surgery, liposuction? Obviously, it's not one size fits all, and certainly it's not something that you can diagnose or recommend, but in general, what are your thoughts on surgery?
Can I just address first the losing the weight and then regaining and then losing again, and how it seems to be not working as good this time? That something, when you lose and regain weight repeatedly, it does screw with your metabolism. And so there could be something happening with the metabolism that is not the same as when you were in your 20s and 30s, how you respond to different foods, and not even just, you know, everybody responds to low carb, high fat, moderate protein, but then with all those specific foods that are in that, you may respond differently. For instance, in our group, some people have a real tough time with nightshades. It's inflammatory, and they did fine on those when they're in 20s, but now they cause water retention and they're inflammatory and they're causing a weight loss stall. So, so sometimes it takes a little bit of what we call biohacking and figuring out what is going to be good for you within that keto spectrum. What are those particular foods that are going to work best for you? And so we recommend using coaching and stuff like that to help you figure that out. The other thing is that how your thyroid can get screwed up too. And we have a practitioner who is helping us, guiding us on helping women to get tested kind of a different way than is traditionally done for thyroid. Because if you're getting that famine response hypothyroidism, you can do whatever you want and even do surgery. And I guess we're talking about bariatric surgeries, but it's not going to work if your thyroid's off. And we need to get that adjusted so that it will allow your body to lose weight.
And before we go into the surgery part of the question, I want to follow up because not everybody in the audience is familiar with the term nightshades.
Yeah, so nightshades is a class of vegetables that is peppers, potatoes, eggplant. And these are things, I mean, especially the peppers and the eggplant could be considered keto foods, but they may not be. Tomatoes, you know, a big one. So if you're Italian, you used to eat a lot of tomatoes like Catherine, you know, yeah. So it's considered to be on a keto diet, but maybe for you at this time in your life, not so good.
Understood. So let's speak to this question that's come up several times in the Q&A today about surgery, liposuction, general opinions about that. Dr. Carmody, would you like to speak to that?
Sure. So when I think Catherine and I were working on lipedema, we realized that the Europeans were way ahead of the Americans in terms of their addressing this entity, lipedema, as a separate, and that they were ahead of Americans by far in developing surgical techniques. Here's what's challenging about the surgery. Can you imagine that you're going to remove the fatty tissue, the adipose cells, and at the same time not injure your lymphatic system, not injure your vascular system? So tumescent, that is putting a lot of fluid into the tissue, liposuction was the technique that they settled on that caused the least damage. The expertise on that particular method that seems to cause the least damage is present in European countries in certain centers. It is in very poor representation in the United States. Very few surgeons have done it with success and repeatedly. I think that Catherine's site has some of those surgeons, but I'm going to tell you they're few and far between. And so the first thing is that though you may go in that direction, the expertise to actually have that surgery successfully and without damage is unfortunately in very small supply in the United States. The second thing is surgery for obesity. If you do have that, in addition to liposuction, is a different issue entirely, you know, and that surgery is well developed, done well in the United States. So if you were doing it you knew that you had both obesity and lipedema, and that with your physician, you were saying that I am having dangerous complications of my obesity that we don't see in lipedema so much, but in obesity, we definitely see people have more heart disease. We have them see them having more cancer, etc. Then having surgery may be the intervention that you need, well developed in the United States, and if applied appropriately will give some result. If you can avoid surgery, it is, you know, I don't think that there's a lot of complication with obesity surgery, but I think lipedema surgery is, boy, it's pretty tough in the United States.
Did you want to add something, Catherine, to that?
I had liposuction surgery for lipedema. I had 2 surgeries. And I have to say that personally, when we first started this exploration, I was looking for a magic bullet. And I was hoping that there was a quick solution. And I have to say that it was not. My first surgery went okay. My second surgery was very, very difficult. I ended up with some pretty severe complications. And through the process, of course, I know many women, and many women have gotten in touch with me. I want to be really clear. For some women, it works. It doesn't work for all women. And there have been cases, you know, it seems like it's very simple. You know, you intubate lots of lidocaine in the tumescent solution, you take out the fat tissue, and then you heal and you're okay. There've been a number of deaths. There've been a couple women who've had to have their legs amputated. One woman got something called compartment syndrome. So the reason I say that is that it's not a haircut. You're not going for a haircut. And there was a way in which we all thought, oh, we'll get liposuction and it'll all go away and the lipedema fat will be gone and we'll lose weight and yada, yada, yada. And for some, it's worked, but there have also been a significant number of women who've had further complications, and I know of several cases where they've developed lymphedema as a result of the liposuction.
Problem upon problem.
Mm-hmm.
Another question here, and thank you for those comprehensive answers. I think that we can't caution enough that it's not just a quick fix or a Band-Aid. Penny Pursuti wants to know, have you found in many of your patients that there is a consistency of possible issues with thyroid and insulin? And what are some possibilities that cause the estrogen dominance at the times of puberty, pregnancy, and menopause? Who would like to speak to that?
I will just make a brief comment. I think, and not this, Leslyn is actually in the process of sort of saying we need to put together a study on this because we don't know what is behind it, you know. And so I could say that the estrogen is extremely confusing because in the state of when you have an onset of menstrual periods in menarche, there is a high estrogen level. And so it may be that high level may be driving the the lipedema to occur. However, in menopause, the estrogen is going down and down. And yet the lipedema sometimes has an onset in menopause. So what the common feature is changes in the hormone field. So the other times there's changed hormone fields during pregnancy. So those are the times that actually lipedema comes. So saying it's too much estrogen, too little estrogen, this is a study issue. And I do have the same opinion about thyroid. Not enough studies, not enough data to actually draw a conclusion. I think that it'd be interesting for Leslyn and Catherine to speak to this.
Leslyn,
Yes, we're, like Catherine said, we're in the process of writing a paper. And one thing that we're looking at with Carol Rosamond, who's been doing a lot of stuff with thyroid and now has been seeing women with lipedema, that she feels like she's seeing a lot of women with this famine response hypothyroidism. And so if we're able to put together a really good research study, we would like to look at those thyroid levels and then actually see what happens to them with the intervention, but also addressing the thyroid issues to help them be more normal and see if they're now able to achieve, help them make the keto diet more effective or something like that. But there's simply not enough data. There's been some small reports that they looked at thyroid levels in a group of patients at the Foley Clinic. So that might be an issue. And like Dr. Carmody said, it's really paradoxical when it comes to estrogen, because it's times of high estrogen and low estrogen that we seem to have an onset of lipedema. So we're not sure what's going on there.
Before we move forward, did you want to add anything to that, Catherine?
I just want to say that if you recognize certain symptoms in your patients that have to do with hypothyroidism, fatigue, very cold extremities, loss of hair, it's not just the famine response, stalling and weight loss. It's so important to have the right testing done, because typically you're going to get tested for TSH, and you need to be tested for T3 and T4, which are the components. But it's only when you get tested for the components that you see that there is in fact an imbalance.
So we still have a host of questions. We're going to try to end promptly at 2 p.m. We're going to get to as many as we can. Some of them are folks that would like us to kind of diagnose them, and we're not going to get into that in this webinar, but we do hope that you can connect with a practitioner who can diagnose and help you appropriately. Another grouping of questions is about payment for treatment. And one in particular from Naomi Moran is, what is the ICD-10 for lipedema, to which there is a collective groan in the room, correct?
So ICD is in process. There is a ICD code coming up in the next iteration. In this one, not that I was lucky, but I had lymphedema, so we were able to code for lymphedema. And there's a code for unspecified edema, and there's a number of other codes. If you go to the lipedemaproject.org website, under the tab, in the navigation where it says lipedema, if you go to differential diagnosis, there's an entire chart, and at the bottom, we list a number of codes that several of the doctors have used. It's difficult depending on what you're trying to get covered by insurance.
Excellent. So there are also questions about the pneumatic compression. And I know that you said that you use the LymphaPress. There were some comments about other pneumatic compression devices that are not the LymphaPress. Can you speak to ease of use? Because for lipedema patients with limited mobility in some cases, it's got to be easy to use or else it's not going to work.
Oh yeah, I can talk to that, because I've had LymphaPress is my third one. I had one, and it was it had ankle, feet to thigh, upper thigh, and I was getting fluid pooling in my upper thighs, and it was not good, and it took me a while. I'm sorry, I'm going on a mini rant. I was using Tactile, and it was like getting into a straitjacket, and I have to say my compliance went down. When I got the LymphaPress, it's just easy to use. And let me also let everyone know, I'm not under any agreement with LymphaPress. I don't see a penny. We recommend LymphaPress for our people. Again, the only reason why is because I use it and it works. That's as simple as that. So it was able to do for me what I needed, which was my legs and my abdomen. And then I also got a jacket for my upper arms. And so, as I said at the beginning, I actually love it, and I use it, as much as I can. And, sometimes when people ask, we just say, talk to Eric. Eric is the guy in the U.S. who runs, who can help you decide if it's right for you or not. But we've had a number of our women get it. And I use it in conjunction with my compression hose. So I still wear compression. I don't wear it 24/7 anymore. There was a time when I was wearing it all the time, but I still wear compression. I use the vibration machine, the vibration plate. And the new thing is we have a community group, the tribe that we're talking about. We exercise together 4 days a week. And so we do stretching and all kinds of body movement. And it's kept us accountable. It's amazing. It's fun. So the combination really helps. I hope that answered.
I just want to follow up because we talked about the ease of use, and we know what many of the people in the audience know what LymphaPress does for lymphedema. What does it, and you're a patient and you use it, what does it do for the patient with lipedema?
I think Dr. Carmody's slide where he showed what happens with compression of any kind, it actually helps from my point of view, it helps stop the progression. And I'll let him address it more because it was with him that I got the prescription for it and whatnot and went through the different pumps till I got to the LymphaPress.
We would love to hear what you have to say on that, Dr. Carmody.
Okay. I think that there is, I think Leslyn has a perspective here from the physical therapy, advanced physical therapy, complicated physical therapy point of view as well. So I can tell you that most patients benefited from some type of compression, be that manual lymphatic drainage plus compression clothing, plus pneumatic pumps of some sort. Most people will actually probably have some benefit, and it will be in sort of the symptom of my legs are just so uncomfortable and I'm living my day in a very uncomfortable way and I'm dragging myself around and I'm in a lot of pain. So I think it really does help with that. You heard one of those patients say, I just wanted to not do what I needed to do every day. And I'll tell you, and this is true of any change that anybody makes in their life, it is burdensome. It is hard. It crowds the rest of your life. So you can add this and see if you as a person can make room for it. And out of whether there is benefit or not, I think that there's enough scientific understanding of how the lymphatics work that it would be beneficial. But can you integrate it, into your life? I think that you have to go and try. I don't think that it's a home run for everybody. But it's, it is a commitment, on your part, and it takes space and time, and your body wants to want it.
Yeah. And what we find is a lot of folks enjoy relaxing while they're pumping, and they've just made it a part of their routine. I want to squeeze in a couple more questions, and Leslyn, this one is right up your alley. A couple of questions about the RAD diet versus the keto diet, and how much protein do you recommend a day? Could you answer that one for us?
You bet. I was just typing an answer to one of the persons who asked about the difference between keto and RAD. So in my presentation where I was talking about calories in, calories out, that plant-based, low-fat way of eating, that's basically the RAD diet. It's a plant-based, low-calorie, low-fat diet. What we're finding, and this is, again, without research, it's just anecdotally, what we're finding is that it doesn't seem to help with lipedema, that you will lose weight on the upper body. And for a lot of women, you'll have increased water retention, you'll have increased pain. It seems to increase inflammation and with lipedema. So it's not something that I would recommend, but there are women that use it and they find benefit from it. I mean, just because we have those individual differences and individual responses to foods. But that's basically the RAD diet. The keto diet is going to encourage some animal source foods. It's not going to limit your access to fat, having that to satiation and getting plenty of protein. So that's how they're different. Was there another part to that question besides differences?
It's about protein, but you know what? I want to give us a chance to promote. You have an upcoming conference which could answer a whole lot of questions from the audience.
Yes. Yeah, so and we are talking about having a conference, the Ketogenic Solution to Lymphatic and Fat Disorders. It was going to be held live in North Carolina, November 6 to 8, but now we're talking about a virtual option. So be looking out for information on that. But we are going to be having speakers who are researchers, who are clinicians, who are people who have these disorders and using this way of eating, and they're going to be talking all about these types of issues and giving you more specifics. Yes.
Wonderful. So on that note, I want to read Carmen Costello's comment, which is, and especially to our fearless tribe leader, Catherine Seo. Are you aware of just how much you have all helped me and so many others find a modicum of hope today? If not, please know I am grateful. Thank you for sharing your time, expertise, and resources. You have all provided a much needed infusion of positivity in my mindset. Now, it is raining buckets where I live, so it sounds like applause, and I think the entire audience is applauding. Thank you, Leslyn, Matthew, Eric, Lympha Press. You will get plenty of links to find your tribe when you receive an email after this event, 24 hours after this event. Thank you all, and thanks for joining us, folks. We really appreciate you being here today. Have a great day.
Thank you. Thank you, Brenda.
Thank you, Brenda.
My pleasure.